Good evening, everybody. Thank you for attending the Whole Again series of webinars. This is the last one for the year, and some of you guys chose this topic. Can type 2 diabetes go into remission? So let's start. For those of you who want CPD certificates, this is a message from Leonie. You got to go and click the link in the chat box and then do your thing and give it about 2 weeks to process. So, is remission possible? And the answer is, of course, yes. But let's go through the details of it. So, before we look at how type 2 diabetes may go into remission, we need to start with the basics and understand what is type 2 diabetes, when does the process actually start, what's in our armamentarium, and then how do we use it to achieve remission. So we need to understand that if you look at this graph, once you diagnose type 2 diabetes and you basically diagnose it here, you need to understand that the process of beta cell loss started at least 10 to 12 years ago. So if you start with 100% beta cell population and you've got insulin resistance, over a period of time, there is progressive beta cell loss. And what happens is there's a slow decline in the number of beta cells. And that means there's less cells to produce insulin. And so you'll go through phases of impaired glucose tolerance, and then a period of postprandial hyperglycemia, and eventually you develop type 2 diabetes. And by then, you've lost a lot of your beta cells as well. The further down you go on this curve, the more difficult it becomes for you to achieve remission. So if you look at, I explain to my patients, there are different phases to you developing type 2 diabetes. So you've got normal glycemia, normal response to insulin, and that over a period of time, if you've got the genetics and poor lifestyle, you're going to move to being insulin resistant. If that's left untreated, you're going to get to a point of prediabetes, and then from prediabetes to type 2 diabetes. Your client's not going to understand the whole impaired glucose tolerance and postprandial issues. So that's a nice simplistic way. And the earlier you start in managing this, the better you're going to be at it. So the definition of type 2 diabetes is when your fasting blood glucose is above 7, or you can use the 2-hour glucose tolerance test. And if your 2-hour level is above 11, then you've got the diagnosis. Provided there's no hemoglobinopathies, if the HbA1c is above 6.5, then you've got the diagnosis as well. So let's look at the current challenges with the classification system. I know when I was born into medicine, you had type 1 diabetes. Typically, you were told that's the kid who's below the age of 18, presents in a catastrophic state, in a DKA, and is going to require insulin from the word go. And then you had type 2 diabetes, where the patient was more obese, and that happened over a period of time. And then there was gestational diabetes and pancreatic diabetes. So at the moment, the thing we're struggling with in the field of diabetology is the imprecise and ambiguous definitions of type 1, type 2, and LADA. So your classic insulin-resistant associated type 2 diabetes, you see every now and then may display some hallmarks of type 1 diabetes. And then you get your classic obese-related insulin resistant patients, and they present with textbook type 1 diabetes on presentation. So, and there's also lack of consensus on whether LADA, late onset diabetes, constitutes late manifestations of type 1 diabetes, or is it early or very fast destructions of beta cell in type 2 diabetes? Excuse me. These are not my dilemmas. This is published work by DeFronzo, who in a big way contributed a lot to the field of type 2 diabetes. So in 2009, that's over a decade and a half, DeFronzo highlighted the need to address the 8 core defects in diabetes, and they called it the ominous octet. And to address these 8 issues would be a way to comprehensively have a therapeutic approach to managing type 2 diabetes. So a new beta-centric model expanded the number of pathological targets from 8 to 11. The culmination of genetics and environmental insults converged, and now you're sitting with 11 different pathways that need to be managed to have a good outcome in your management of patients with type 2 diabetes. Now, they also talk about, and this was now already a decade and a half ago, that the optimal therapeutic strategy should be a patient individualized regimen. So you can only individualize your client's treatment if you actually know what the diagnosis is, what the cause is, and whether you have the right weaponry to manage that. So let's look at this 11 interlocking pathways. And for some of you who've managed to come to talks on type 2 diabetes at other CMEs, forgive me, this is a slide that we commonly use, but I think it's important to cover here. So central to type 2 diabetes has always been the beta cell. Certainly when I was born into the field of diabetes, it was quite easy. You got the diagnosis of type 2 diabetes, you told the client, go on a diet, go and exercise, and we'll see you in 3 months' time. In 3 months' time, if the HbA1c was still above 7, then you would say, right, we're going to start glucophage, metformin. And you give it 3 months, and if the patient's HbA1c is still high, then you would add an SU, a sulfonylurea. And 3 months later, if it was still high, you would then initiate insulin. So it was a stepwise approach without thinking much. All you needed to look at is the HbA1c. And if you didn't get to target, you just move on to the next one. And if you didn't get to target, you just move on to the next one. So every patient with type 2 diabetes got the same copy of the script because that's all you had. That's come a long way because we have a better understanding now in terms of all the different causes, but also our armamentarium in managing these conditions have increased. And so the old way of thinking was it's not specialized to any particular individual. You're just sitting with one cause, one diagnosis, and that's the way to go. And of course, that is why we still have so many people with type 2 diabetes that are not well controlled and have already complications. So when you talk about the pancreatic beta cell, that's the cell that makes insulin, and the pathology in type 2 diabetes is that there is actually an overproduction of insulin by the beta cell to overcome the resistance because the peripheral cells, the rest of the cells in the body, don't want to take up glucose. And so that's a problem. So in order to force the glucose in, to open up the gates, so to speak, in the fat cell, in the muscle cell, in the liver cell, whichever cell requires the glucose, you then up-regulate the production of insulin. And so if insulin had no other function in the body, you'd be okay. because it would eventually force the glucose in. The problem is insulin is also a growth hormone, and therein lies the problem. And so that was the basic understanding. And so eventually the beta cell dies out because the beta cell mass decreases, and then you need insulin, right? But there's also something known as the incretin effect. And this was picked up where if I'm infused with glucose and I look at the insulin response, as opposed to be orally taking insulin and looking at the response, the difference we see is called the incretin effect. So this shows that there's something happening once we orally ingest glucose that is different to when it comes through an IV. And later we found out that the incretin effect is where the GLPs actually come in, right? GIP and GLP. The third aspect is that the pancreatic cells also, or the pancreatic organ, sorry, also has an alpha cell, and that produces glucagon. And now we know that the relationship between insulin and glucagon, the partner hormones, is very important. The net effect is that if you can't produce enough insulin to overcome the resistance, you've got a decreased incretin effect, you've got a problem with glucagon, the net effect is hypoglycemia. The organs that are insulin resistant, and this was known a long time ago, would be the liver. The liver receives the bulk of the insulin that is produced in the body, and it gets it directly from the pancreas even before the insulin goes out peripherally. And so here, the liver is also important because it stores energy in the form of glycogen, and glucagon and insulin plays their role there. But you have the peripheral tissue like muscles and fat cells that are also insulin resistant. So then came the role of the brain, where we realize in and around the hypothalamic area, there are centers that control appetite. And in somebody with type 2 diabetes, they have an increase in appetite. That means they feel hungrier earlier than a non-diabetic, non-insulin resistant person. There's also decreased morning dopamine surge, so the reward center gets affected, and there's an increase in sympathetic tone as well. So the interplay between satiety and appetite becomes dysfunctional in somebody with a type 2 diabetes brain. The colon plays a very important role, and I think that's where a lot of our successes, even before the GLPs came about, in terms of trying to reverse patients' type 2 diabetes. But now it's a known fact that the gut microbiome not only influences obesity, insulin resistance, appetite, the production of the neurotransmitters takes place at that level as well. And your digestion and immunity is very much dependent. And we've done multiple talks on the gut microbiome. And it influences GLP secretion as well. And then you've got immune dysregulation. So type 2 diabetes is actually a condition primarily of low-grade inflammation with insulin resistance, and that milieu ends up in a lot of other issues. Then you've got amylase, an enzyme that's produced in the pancreas, and when the levels drop, it already tells you that there's a problem from a production perspective. Amylase is also incidentally very important in terms of digestion. Then the role of the stomach and intestine is important, because remember, the stomach is what churns everything and then slowly supposed to let it out into the intestines. And then what happens is, in a patient with type 2 diabetes, there's dumping of glucose as opposed to slow release. And then lastly, the importance of kidney. So glucose is much like petrol. It's inflammable, it's dangerous. And just like you contain your petrol in a car in a closed loop system, Same thing happens with glucose. And so when you eat, you get a surge of glucose, and then it gets packaged and put away. And then in case the glucose levels are too high, the kidney has a Tmax where beyond a certain number, the body releases glucose and you just pee it out, glycosuria. That is why 2000 years ago, even some of the Greek doctors used to make the diagnosis of diabetes by tasting their patient's urine, and if it tasted sweet, then you would know the patient had diabetes. And so now we know that in diabetic patients, the kidney releases glucose much later. In fact, so there the kidney is primed to actually hold on to glucose. So can you see, you're holding on more glucose, you're dumping more glucose into the system very quickly, you're having an abnormal milieu of insulin and glucagon. The organs that are meant to take up glucose and use it are a bit resistant. The brain is foraging more. The gut microbiomes playing their role, and inflammation, and the net effect is you're sitting with type 2 diabetes. So here's the issue. The proposal is that going forward in the coming years, the entire way of diagnosing diabetes is going to change, because at the moment I spoke to you about categories of type 1, type 2, gestational, there's pancreatic diabetes from pancreatitis and LADA, but there's going to be 7 different subtypes just of type 2 diabetes. And so whilst at this point in time we use H1C fasting glucose and glucose tolerance tests to make the diagnosis of diabetes, you're going to see going forward, we actually, on all patients, are going to have to probably do C-peptide, islet cell antibodies, other inflammatory markers, measures of insulin resistance, which currently everybody frowns upon, but yet we use it in every clinical trial with type 2 diabetes. So the HOMA index, beta cell mass, markers of environmental damage, mediating pathways for hyperglycemia, and then genotyping. And based on that, you will be able to individualize your client's treatment. Lifestyle modification is always going to be underpinning all of this. And then pharmacotherapy, suggestion is preferentially use agents with strong evidence of beta cell preservation. Don't kill them. Use the least number of agents to target the greatest number of mediating hyperglycemic pathways. So in other words, try and address all the pathways, and if you can do so with the minimum amount of products, do so. Use regimens that stabilizes hyperglycemia across multiple causes synergistically to reduce cardiovascular and other risk factors, but also preserve beta cell function. So the ADA, and this is the most widely used guideline, but it's not a guideline, it was a consensus statement, right? Shows you how to manage patients with type 2 diabetes. And it's important to know how to manage patients with type 2 diabetes, because we know that only then can you talk about reversal. You first need to get your client well controlled before you can reverse them. So gone are the days where you exercise, 3 months later you add metformin, 3 months later SU, 3 months later insulin, if along the way the H1C targets are not below 7. So first line of therapy from the onset of diagnosis, metformin, and preferably you would have diagnosed pre-diabetes and the patient would have already been on metformin with comprehensive lifestyle. So it has to be started together. You don't wait for the one, so you don't treat for failure, because that was the old model. You treat, and when you fail, then you add. You treat, you fail, then you add. And then by then you're losing the battle already. So here they're saying from the get-go, metformin, lifestyle, intensive lifestyle targets, and what you're trying to do is achieve that H1C target as quickly as possible, but also aim for the client to lose at least 5 to 10% of their weight. And once you're doing that, the next thing you need to put in mind is there established cardiovascular disease or kidney disease? If it's yes, you go down the blue path. If it's no, you go down the brown path. So I'm just going to bypass all of this, and it shows you algorithms. And we're going to go through this in details. So if you've got established cardiovascular disease, the approach is GLP and SGLT2s. If there is no established cardiovascular disease or kidney disease, then the next consideration is use a product to minimize hypoglycemia. Don't use anything that can potentially cause hypoglycemia. In other words, you could add to metformin, DPP4 inhibitor, you could go a GLP receptor 1 agonist, SGLT2 type 2 diabetes. You must also make sure that you minimize weight gain and actually promote weight loss. So in order to do that, it best be a GLP-1 or an SGLT2 based regimen. And only then should you consider cost. And if cost is an issue, use SU and TSZD. And yet, every day I get patients with type 2 diabetes in my practice still on an SU, and sometimes they're only on an SU. So here, you've got your diagnosis of type 2 diabetes, metformin, diet, exercise, and the first thing that should go through your mind is to say, is there risk of atherosclerotic cardiovascular disease? If the answer is yes, use a proven GLP-1 receptor agonist. If the client can't afford it, or they used it and they got side effects, or they used it but you didn't get to a good HbA1c, switch or add SGLT2. Simple. Either GLP based or SGLT2 based. If you got a patient who's got heart failure or mainly kidney disease, so it's not atherosclerotic but more kidney and heart failure, then start with an SGLT2. If you've got side effects or if you haven't managed to reach target, go for a GLP-1 receptor agonist. When you use these two, or either one on its own, if there's side effects and you still haven't got target, that's when you need to go to a DPP4 inhibitor. If the client is not on GLP, so SGLT2 and DPP4. And if that's not enough, basal insulin, if that's not enough TZD, if that's not enough SU. Can you see SU is still last on the list? Same thing here. And then you've got choices of how you would choose the SGLT2s or the GLP. The compelling need to minimize hypoglycemia. Use an agent that can't cause it. So you know metformin can't cause hypoglycemia. DPP4 inhibitors don't. Minimal. GLP receptor 1 don't. SGLT2s don't cause hypoglycemia. TZTs don't cause hypoglycemia unless they're used in conjunction with insulin and SU. And I'm not going to go through the whole algorithm. There's not a talk on type 2 diabetes. So, and then only if that doesn't work and cost is an issue, then you go on to an SU. Now, why are we doing all of this? Because type 2 diabetes is the second biggest killer of people in South Africa. And how do they kill? Through microvascular, macrovascular complications. If it's macro, heart attack, cardiac failure, strokes, peripheral vascular disease, microvascular, blindness, diabetic disease and kidney dialysis, diabetic neuropathy, which can end up in amputation. That's why we're doing all of this. So despite knowing all of this for the last 40 years, only 50% of patients reach HbA1cs below target. The other 50 are not. Over 90% of them still remain overweight and obese, and that in most of the patients means you're not going to get reversal. And so therein lies the problem. So what's the problem? You think we don't have enough weaponry? So if you look from 1920s onwards, right up to now, there's been a surge in the number of products that can be used for you and I to manage our patients a bit better. And if you look, a lot of them were concentrated here. So I don't think it's a lack of armamentarium. You need to know where the products work and how you need to use them. So acarbose, which is not in South Africa, but very popular in Asia, basically decreases the breakdown of carbs and then decreases the absorption of it. So basically you pass it out in your stool. And it acts as a fiber, so it swells up, and then whatever glucose you can absorb, it slowly it increases the excursion. So it prevents the dumping of glucose into the intestines. Metformin, pioglitazone, insulins work at the level of the muscle and fat cells for them to take it up. The SGLT2s make you pee out sugar. We spoke about insulin, the SUs, the short-acting SUs, GLP-1 receptor agonists and the DPP-4 inhibitors. They work on the beta cell, and then metformin, the GLPs, DPP-4 and insulin works on the liver, and then the GLPs also work on the brain. So all of these are insulin-dependent pathways, and this is the only insulin-independent pathway currently. So let's speak to quickly go through the mechanism of action. You need to know how your weapons work. So what does metformin do? It never causes hypoglycemia. So how does it drop sugar? It gets the intestines to use up the glucose more easily. It gets the liver to decrease gluconeogenesis. So you don't produce glucose from amino acids. You don't produce glucose from the glycogen stores, and you decrease fatty acid oxidation. You get metformin to get the muscles to take up glucose a bit better. You increase glycogenolysis, the use of these glucose stores, and you decrease fatty acid oxidation. And the net effect is you get hypoglycemia. So you're getting hypoglycemia not by directly dropping glucose, but getting these peripheral insulin-resistant organs to utilize the glucose a bit more cleverly, work on fatty acid oxidation, because high triglycerides begets toxicity to the beta cell. So it's got its pros and cons. So it drops the H1C quite significantly. The higher the H1C, the bigger the drop. It's weight neutral or can even drop weight in some patients. Extremely low risk of hypoglycemia and potential cardiovascular benefits. Cons, GIT disturbances. So first line of treatment. And we forget that years ago, the UK-PDS study showed there was already evidence of cardiovascular benefit, and this was in the sub-study 34. And you can see showing cardiovascular benefit. So it's not that the SGLT2s and the GIPs were the first to show that, right? GLPs. It's just at those days, they were not looking for cardiovascular benefit, but there was already hint in that study. The SUs, my least favorite of the diabetic products. What's its mechanism of action? So there's the pancreas, there's the beta cell enlarged. You get channels that will guide potassium, and you get channels that guide calcium, and the interplay between calcium and potassium channels will then influence the influx of glucose and insulin. And so the SUs basically work on these channels, and you have depolarization, the release of insulin into the peripheral system, and that's where you get insulin secretion. So how do they work? Well, they drop the H1C also significantly by about on average 1%. They can be used as initiating or more commonly as an add-on. Risk of hypoglycemia is high. The problem is weight gain. Now, those days you had nothing else except glucophage and SU. And those days we used to think the problem with type 2 diabetes was a high sugar level. It never was. It was a problem of insulin resistance. It was a cardiometabolic condition. Insulin and glucose happens to be one aspect of it. And weight those days was just more phenotypic issues. It wasn't a medical condition. So when you caused the patient to put on weight, nobody really gave a shit. But to put on 2 to 5 kilos every 6 months is a problem. Because now we know in 85% of patients with type 2 diabetes, it is the underlying obesity, the visceral fat that is a problem. And so here, there were always concerns with cardiovascular outcomes. And so from that perspective, that's why it makes it into my least favorite drug. The TZTs, PPAR agonist, mechanism of action, much like if you look at the picture, what metformin does. And it does so through the PPAR gamma activation. The net effect is that you have a decrease in plasma-free fatty acid levels. And the less fat, the less triglycerides in the system, the less toxicity to the beta cells. The beta cells work better, produce more insulin, and the net effect is the sugar levels go down. Drops the HbA1c, low risk of hyperglycemia when it's used on its own. Cons is weight gain, but when you take a further look into the weight gain, it's mainly fluid, right? It's not an increase in fat. There was an issue with anemia, and there is an issue with congestive cardiac failure if you've got underlying cardiac issues. And then potential cardiovascular risk. And so in 2007, they realized that there is a difference in the different types of TZTs. So the cardiovascular issue wasn't a class effect, that it was only found on rosiglitazone where the risk of myocardial infarction and death was higher. Remember, anything on this side of the forest plot is a problem from a cardiovascular risk. So, and then they looked at pioglitazone, another type of a TZT. There wasn't an increase in death. So that's why pioglitazone still exists and Rosie doesn't. But what is important, that it was this drug, we must thank this drug for the fact that the FDA changed their laws in terms of what is required to register a new drug for diabetes. And henceforth, from 2007, the FDA said there's new requirements and say, for you to now register a product for type 2 diabetes, not only do you need the old-fashioned requirement of dropping the HbA1c by 0.7 against control, but you must also demonstrate cardiovascular safety. Otherwise, even if you got the cure for type 2 diabetes, but as a side effect, you're going to increase cardiovascular death, it can't come on the market. So henceforth, every new drug had to prove cardiovascular outcome data. So when you go back to say, but why wasn't these guys asked to do a cardiovascular data? Those days, cardiovascular thing wasn't of concern, you see? And so henceforth, all products had to show proven. So no cardiovascular harm. So you have to be neutral or actually decrease cardiovascular risk. The DPP-4 inhibitors, these drugs were supposed to be the death of SUs, and yet we still used SUs. So why did these drugs come out? Because you wanted to make sure that you got a drug that can stimulate the beta cell to cause the release of insulin, but when the sugar level starts dropping, that it stops working and that you never get hypoglycemia. And then the DPP-4 inhibitors are the enzymes that will actually break down your native GLP. So for those of you who don't know it, guess what? You are making GLP every day in physiological levels, whereas the drug gives it to you in pharmacological levels, right? And the role of GLP was also always to slow down gastric emptying. So by using this enzyme, you don't break down GLP, you let it last there but longer, and then you have decreased gastric emptying, you have the GLP effect, and I'm going to go through it later in terms of everything it does. So why use a product that is like an SU, much lower risk of hypoglycemia, if anything, no weight gain, can be used as monotherapy or add-on, no excess cardiovascular death, so not improvement, but at least not increasing. And the cons was that just with one particular type, there was an increase in hospitalization for heart failure, and we never even had that drug on release. And then with any of the SUs, there is a small risk of pancreatitis. And yet we're still using SUs, even though the DPP-4 inhibitors are here. And then early on, people say, oh, they were expensive, and now these guys are cheap, and there's 400 generics, and people still use SUs. The GLP-1 receptor agonist, or mechanism of action. Now, all of you guys have been to 100 CMEs and launches on the GLPs. So I'm not going to go through it. But the principle is decrease of gastric emptying, decreases glucose production in the liver, improves satiety, works on the brain, on the appetite center, and works on glucagon as well. It drops HbA1c, very low risk of hypoglycemia on its own, but when used with other drugs like SUs or insulin, it can. You have weight reduction, can be used on its own or as add-on, drops blood pressure, and has cardiovascular benefit. Side effect, quite a high risk of nausea and vomiting initially, but the discontinuation rate, and this data's changed, is now less than 5%, right? If you start slow and build up. Cons, slightly higher risk of pancreatitis, and then it's an injectable. What about the SGLT2? A very clever molecule. How does it work? I told you the kidney's job is to filter many things, including glucose. And what happens is there's two receptors, SGLT2, SGLT1, and they found that if you inhibit this, the body will not reabsorb glucose. Remember, it's the body's job to hold on to as much glucose as possible. For most of mankind's life, glucose wasn't easy to come by. So when you got it, you wanted to store it. So what happens is you filter 180 grams of glucose every day, and that means you would lose a lot of calories. So you had to have a way of holding on to it. And these two will make you hold on to it because they will cause the reabsorption of glucose at this loop of Henle. But now if you block this guy, then the glucose just passes out, you see? Okay? And so you release the extra glucose. So how does it work? Well, it drops HbA1c by 0.6 to 1.2. There's a weight reduction, drops blood pressure, can use on its own as an add-on, no or low risk of hypoglycemia, and depending on which product you use, varying cardiovascular benefit. Problem is, there's a higher risk of thrush and bladder infections if you're prone to it. Now, so now you know how your weapons work. Let's talk about remission. So remission is not cure. You can't cure. Why? Because the basis of type 2 diabetes is genetic. And what is that? Insulin resistance. And insulin resistance is not going to go away. It'll go away one day with CRISPR and maybe a few other interventions, but until then, it's not going away. So it needs to be managed. Now, where did we learn this word remission? From oncology, nephrologists, rheumatologists. When there is no detection of the original disease, that's called remission. But the risk of reoccurrence is always there. So this means that once you've got a client where you've put into remission, it doesn't mean they go away forever. You still got to monitor them closely, right? And the same thing you're doing with oncology, with close follow-up, you're going to do the same thing here with your diabetic client. So what's the definition? Well, it depends. You choose one. Type 2 diabetes remission with no anti-hypoglycemic medications for at least 3 consecutive months and achieving an HbA1c below 6. That is one category of remission. Or you may say you bring it to pre-diabetic level. So you say remission to pre-diabetes. Or you say type 2 diabetes can relapse if it goes above 6.5. Or you can say it's remission because it's pharmacologically managed to a level that you wouldn't consider a patient to be diabetic. So let me just say that again if it's not clear. You could have remission where you use products, but eventually you stop all the products, and 3 months later, without using anything, just with lifestyle, those levels are achieved. So below 6, no diabetes, or you say you got them to a point of pre-diabetes between 6 and 6.5. Or you can say I'm using drugs, so pharmacologically managed remission, where your HbA1cs are below 6. For me, it's 5.6. Okay. Who are you more likely to get remission in? They say people that have been diagnosed in the recent past, so not longer than 6 years. People that are overweight, because now you've got drugs to make them lose weight. So the ones who are overweight have a better chance of going into remission. People with glucose levels that are not that elevated, so somebody's HbA1c of 7.4 is easier to go into remission than 10. And patients that are not already on insulin. But your best way is don't allow the diabetes to happen. So don't sit on your laurels, screen your patients. If you've got pre-diabetes, that's where you want to target the patient. Be firm with your client, and it's not only diet and exercise. Be proactive and intervene there so that you can get remission very early. So how do you approach the remission? Surgical intervention. So bariatric surgery, there are 4 different types, each one trying to achieve more weight loss than the other. But the higher the weight, the deeper the surgical intervention, the bigger the drop in weight, the bigger the complication risk, right? So once you start getting 15%, 20% weight loss from where you are, you're looking at remission. So that the bariatric surgeons have already shown. Pharmacological interventions, which we're going to go through, very important to know that health, behavioral stuff still works. And then nowadays with digital technology intervention, you'll see a lot of the dietitians, nutritionists advise their clients to go and get their glucose monitoring done, even if they're not diabetic. So it teaches them what food's doing to their sugar levels. And so that way it changes behavior. The devices, my watch, I'm already worried today because I've still got to burn 51 calories, and I'm going to be talking to you guys till 9 o'clock. So today I'm behind, and I'm currently on a 24-day streak. So from that perspective, these devices do change behavior. Vitality and discovery do change behavior. Maybe not for everybody, but that's where they talk about technology, right? So bariatric surgery, who must go for bariatric surgery? So it's recommended in non-pregnant adult type 2 diabetic patients with a BMI above 35 with risk factors with a potential hope to reverse type 2 diabetes. But nowadays, with the new GIP, GLP products on the market, the final nail on the coffin of bariatric surgeon, unfortunately, has come. So a lot of them are going to have to diversify a bit more. So in the next 10 years, there's over 20 products extremely promising products that are late in clinical trials that are going to be getting you even more weight loss than current products, more diabetic improvement than current, and there's over 200 in investigation, but 20 already looking promising, right? So nowadays, it's actually easy to reverse somebody's type 2 diabetes. Now, we've been doing it consistently for over 15 years, even before the SGLT2s and the GLPs came out. In everybody? No. So that's why I want to just show you a few case studies. And all of you guys who come to my webinars know that I don't prepare these things before time. It's patients that have come in the last week or two, and then I've got access to the file. I give it to Leonie, and then she types out the stuff. Some of these cases I have gone through with some of you guys before when we were talking about diabetes. But here's a patient, 57 years of age. This Afrikaner couple I remember very well because they come from the Klerksdorp area, and he had type 2 diabetes, but then unfortunately he developed uveitis. And you know how the surgeons are. They love steroids. So ophthalmic surgeons just put these patients on steroids. What else have they got to do? It's not their fault. And of course, it just tips this patient's control over completely. So the guy comes and sees me, and he's on the usual shit medication. And at the time, the SGLT2s had come out, and so I had him on SGLT2s with his glucophage. In those days, it was still separate, and yeah, we gave it. Eventually, actually went on to the combination treatment, and his wife also became my patient, and then she kept coming. But in the last couple of years, he hasn't been coming. And why? Because he also had gut microbiome issues. And of course, we did live blood analysis and we were working on his gut. But he's now off all his diabetic treatment, and all he's doing is paleo. So this is my longest standing patient. It's a couple. She joined him with paleo as well. And they've been doing paleo for 4.5 years and with absolutely no product. And he's reversed his type 2 diabetes completely. So can you use lifestyle to change? Yes. Because remember, as long as you're not taking a carb, the beta cell doesn't have to produce insulin. If there isn't insulin production, you can be genetically insulin resistant all you want to. The game hasn't started, right? So carbs is obviously the cause if the genetic milieu allows that to happen. And so here, he's maintained paleo, all his inflammation's down, that shit is gone, he's no longer diabetic. I haven't even seen him for over 4 years. His wife still keeps coming. So get your dietitians to come and help you. Of course, the meal's got to become interesting, so it's sustainable. But that's why I said, he's my longest standing patient on paleo. It's not always sustainable. Here's another case. So when we went through that list, that's not my list for remission, by the way. This is what the guidelines talk about remission. So one of the things they said is that get the patient early, right? And then the second thing they said is that the more overweight the patient is, the more likely they're going to go into diabetic remission. So I had 2 patients coming towards the end of last week, both Indian. I chose this one, type 2 diabetes, but both of them were reverse, type 2 diabetes at a very young age, and his BMI was 20. So much so that when he was diagnosed in Natal, and now he works here for a bank, they said, no, he's type 1, Indian, thin, diabetic at age 25. They just said he was type 1. And his waist size was 28. So obviously, if we said if this guy is truly a type 2, and he is, because we've proven it, and there's ways to prove it, right? C-peptide and antigens and all of that. So, but he was on long-acting insulin, 30 units, and using short-acting Novorapid, 14 before each unit, but he used to count. So sometimes it's 12, sometimes it's 10, sometimes it's 16, but on average, 14, 14, 14. He was given neurobion because he had peripheral neuropathy, and he was put on vitamin D3, calciferol, once a week. What did we do? Note this BMI. So I stopped. Okay, we don't stop insulin straight away, right? We've done this with you guys before. So we do this, but I also add other products, and then I'll tell the client, check your sugar levels every 3 days. Every morning over 3 days. If the average is above X, adjust it by 2 units, and you keep doing that every 3 units, and then they keep dropping the insulin levels. So I put him on Singlutra, put him on Ozempic, low dose, slowly built it up. His homocysteine levels were high on neurobium. Obviously, he was a poor methylator, so I put him on homocysteine balance that has a methylated folate, methylated B6, methylated B12 with TMG, trimethylglycine, and methionine. The calciferol didn't work. You guys know that it only works if you put the client in the sun. You need 45 minutes, 40 to 45 minutes of exposure to 40% of your body for that to actually meaningfully get that D3 levels up. So I put him on D3 drops, 35 drops per week. He also had thyroid antibodies, and there was a fertility issue. In fact, that's why he came to me. And statin issues, the classic Indian gene, don't marry Indian. And so the role of vitamin D, important for insulin sensitivity, for glucose metabolism. There's a high prevalence of vitamin D deficiency in diabetic patients, and the clinical consequences. We had a whole talk on vitamin D, guys. So if you guys haven't seen it, just ask Leonie. She can send you the link. And we showed how it increased the risk of insulin resistance, cardiovascular disease, bone health problems, right? And so that's important. So whether you give it as tablets, 3,000 units a day, or as drops, you don't need a script. That you need a script in South Africa. And this is mixed in MCT oil, pleasant tasting citrus flavor, and Bob's your uncle. So you can see over a period of time, without insulin use, because of course you can't measure insulin in a fasting state if you're on insulin, because then you're measuring what you've given the client, right? And so here in May, the glucose started coming down, but look at the insulin response. So this started improving, home index started improving, quickie index was improving, and he's now basically off Ozempic. He's off Singlutra, and now we're just managing him with glucophage. So we now showed you that if there is a willing client with extreme dietary intervention, you can reverse it. You don't have to have an obese type 2 patient to look at remission. It can also be done with thin, difficult Indian type 2 diabetic clients. This patient, age 63, type 2 diabetes from 2015, already microvascular complications, was on an ACE inhibitor, statins, metformin, and SU, BMI of 31, blood pressure not bad, LDL good, waist horrendous, HbA1c of 10.8, and we keep reinforcing at every visit importance of lifestyle modification and what were we to do next. You at Barra. I was at Barra because I want to show you that if you know your weaponry and you choose it well, and that's why in the future everybody's been able to choose it well, because you'd have all those tests to work out which category of the 7 different type 2 patients you on, and then you can cookie pick your drugs, right? But Amit Bera, what do you do now? That's why the patient was on SU. I told you I don't use SU, but the Bera got nothing else at the time. There's an old case already, right? And so, do we add insulin? Of course. What else have we got? So we tried very hard to convince her to say, Mama, please, we need to put you on insulin. It's not so bad. We'll show you how to use it. We'll go up slowly. Ta-da-ta-da. No, she doesn't want it. She says, is there something else? So I said, no. She said, is there something else that is natural or something that you can buy somewhere else? I said, yes, there is actually. The SGLT2s just came out in private then. And I said, there is a drug. It makes you pee out sugar. Works very well, but it's very expensive. And those days, there was just the Buringer product. It just came out. It was expensive. And she said, don't worry. I'm going to go home, discuss it with my family. Give me a chance. I'll buy it. Give me a script. So I told her, but the HbA1c drop on the SGLT2 is only 0.7 to 1. But there are other benefits. And then I was involved in the launch. So I told her all the stuff about what it does, right? And so she said, I'll get it. And so the HbA1c was 10.8. The drug only drops the HbA1c by 0.7 to 1. How is it that we got a patient at Bera, the size of a house, on statins, on metformin, on SU, 10.8, and the level comes down? I just wish we always did this in a live audience, because I wanted to ask you guys, how do you think that was achieved? So when I spoke to you guys about the 11 different things that can go wrong in a person with type 2 diabetes, it doesn't mean that every patient with type 2 diabetes got all 11 things wrong. The 11 now, there were 8 before, there was 3 before. 10 years from now, there might be 30 things that we find that can go wrong with the different pathways in type 2 diabetes. So in some patients, one particular cause is the cause, or 1 out of the 4 causes is more dominant, or 6 out of the 11 is more dominant. And so here, all we did was we weren't clever. You just happened to choose the drug that picked the primary pathology of her cause of type 2 diabetes, which was the kidney. You see? So here, it's not really a case of remission, but I just want to show you, because now every person will say, oh, why is he giving a talk on it? It's so easy to go into diabetic remission. Just put everybody on Manjaro. And yet today I had a client from a doctor that used to work for me years ago, excellent doctor, and she initiated a patient at her GP practice on Ozempic for 3 months, and then she was working in conjunction with a dietitian in the Bluebird Center, and that person then through another GP said, can we switch this person onto Manjaro? And yes, so now she's on 2 months of Manjaro. So in total, 5 months of a GLP or a GLP-GIP combination, and she's lost 0.5 kilos. 0.5 kilos, people. And so I just saw now, so I'm going to start working on her. But we told you guys in previous talks that there are 7 causes of weight gain. It could be a mitochondrial problem. It could be a thyroid problem. It could be an adrenal problem. It could be estrogen dominance. It could be fatty liver. It could be a gut microbiome problem. It could be insulin resistance base. Okay? So your GLP, GIP based stuff is going to do bugger all for thyroid. It's going to do nothing for the gut microbiome. It's going to do absolutely bugger all for adrenal. So you've got to, this is now weight now, find the thing. So same thing here with type 2 diabetes. Here, I just want to show you that even when the GLPs were not around, can you see here that particular drug was a game changer. Now imagine, I don't know what happened to her now. I've left Barra 2 years ago, but I'm hoping that she's still doing well. But imagine if now she had to go on a proper lifestyle program, really do what that first guy did, so not extreme as paleo, you've got a big game changer there. Because the first thing you do is drop the SU, because the SU itself promotes weight gain, and then wait it out. And if that's still good, then start lowering the dose of your metformin and SGLT2, and then see where that goes. My third case, I have discussed with you guys this on another platform. I forgot which one, but I told you this case 3 was problematic because her daughter is a doctor. Make sure you don't treat any patient whose family member is a doctor. Too much interference and the consult takes too long. So here's the bloods. So there was a Chamors. Homocysteine was off, poor methylator, statin, so cholesterol was well managed, HbA1c, Chamors 9.9, vitamin D shitty 10. So what was the patient on? Calciferol. I told you guys it doesn't work. So just well marketed. You saw it was 10. Statins worked. Blood pressure was well controlled. There's my favorite drug, SU. Was on Galvus and metformin maximum doses, taking 2 a day, and HbA1c still shit. So I don't know if some of you guys recall, Nadia's got a good memory. She will remember why I discussed this historically with you guys. I don't, but the case has evolved now, so I'm going to just take it one step further. So what did we do? We gave it a try, and there was adrenal issues. Changed the vitamin D to the whole again 3,000 units. So they were getting 50,000 a week. Yeah, you're getting 21,000 a week. The statins are working. Don't break something. Put her on Ozempic, a low dose, build it up. SGLT2. So change the Galvus. And how the hell do you use DPP4 and an SU? And this person was in managed care. Managed care has got a protocol. You can't even make a mistake. You know, they're not allowed. But anyway, so it's like dashing Coke with Coke. But anyway, and then we changed it, and then Prexim, and then iron was still an issue as well. And you see, the lesson here was this husband and wife, they were actually very well off. And you guys will recall her because I told you guys after her, I started seeing all her golf buddies. So this is an Indian woman who plays golf twice a week, and her husband plays golf as well. They're well-to-do. They travel a lot. So the doctor should have bothered asking that, do you guys have financial issues? The daughter was a doctor. So surely you don't have to be on a 5 cents drug and still get poor management. You see, so don't take it for granted that your patients are not going to be able to afford anything. That's not your job. Your job is to say, this is the best drug for you. There's the second best drug. These are the costs. This is why I would like to do this. Is it affordable or not? It's not. Fine. You move on. There's no shame in that. But this is when you make assumptions that the whole world's poor and that you have to follow your boss who is the medical aid, right? But that's what we did because we don't give a shit about money. And so what happened? Look. So from that perspective, her latest HbA1c is now 5.5, currently only on glucophage. Antihypertensives have now stopped because once you get significant weight reduction, because remember the SUs make you put on weight, and of course doesn't give you control, whereas these drugs will get you weight loss. And once, and we've done the talk on the GLPs and on obesity, once you get 10% weight loss, blood pressure starts disappearing, cholesterol starts going down, fatty liver starts improving. Once you get 15% weight loss, you prevent pre-diabetics to go to diabetes. And once you get 15 to 20% diabetes remission. Okay. And then we have the statins as well. So from that perspective, here, don't make decisions on behalf of your patient. present to them all the options, go through the pros and cons, and give them a chance. 69-year-old male. This patient has been with me for over a decade. He was in the government, left government, thank God, a very well-respected advocate. He keeps telling me I'm allowed to use his name, but I still don't. But he came to me with fatty liver. Him and his wife were in politics. His wife was my client for a long time. Kept nagging him to come and see me. He didn't. Then he came to see me once, and then he was going for quite a high-profile job in government, got busy, left it 3 years later, came back to me when he decided to leave politics. But to cut a long story short now, he was in politics. That means if you're in South African politics and you a minister, you can afford anything. Even 3 Lamborghinis of the same color. So 8.4, 8.3, 8.4, 9, and then we come into the good numbers. Thyroid was fine. He had testosterone deficiency all along and converting testosterone to estrogen. Okay, no, sorry, guys. Wrong patient. Right, no, this is another one. So the politician we're coming to now. Okay, so here, testosterone issues, same scenario. So what was this patient on? So this patient was getting treatment at a managed care facility. That means they worked for a capped amount. The medical aids forced patients to go and see those people, and they manage them very well, but for a capped amount, so they can only use certain products. Thankfully, that is changing, which is good. And this patient was on glucophage, my favorite drug, opticillin 10. So now, that guidelines on remission said, if a patient's on insulin, very difficult to reverse, right? Okay. So, HbA1c 8.4. So went to another endocrinologist, but this endocrinologist is not part of managed care. So this is independent. They can do whatever they want to, choose whatever drug. So they carried on with took the SU and glucophage and carried on with oral treatment, changed it to Genumed and said, no, you need better control, nothing wrong with that. Increase the opticillin, and which is once a day long acting, but decided to split it in any way. And so, whole and behold, unfortunately, the HbA1c went up a bit. And then we gave it a go. And so I said, SGLT2s, let's get the urine to the kidneys to work for us. Glucophage, still my favorite drug, carry on. Blood pressure, we carried on. Zuvabor, and then Zaltify, I was involved in the launch of it, had just come out. I said, listen, there's a GLP-GIP combination drug, and that will allow me to at least reduce insulin use by 20%, and at least we will have an impact on your weight, and let's see where that goes. And so from 2021, 2022, 2023, can you see what happened? But then, as you guys know, Zaltify left the market because of shortages, and we slowly started moving on to just the GLP and not the insulin. But here, the reason why I want to point out this case is that I want to show you the importance of other conventional hormonal approaches that are not based on those 11 factors that I spoke about earlier. So, testosterone deficiency is a thing, especially in males with type 2 diabetes. So 50% of patients with type 2 diabetes will have testosterone deficiency, and 30% of type 1 diabetes. And that is not age related. Of course, if they're old, it's going to get messed up even sooner. And so one needs to realize that it's a clinical and biochemical syndrome associated with advancing age and has characteristic symptoms and deficiency like any other disease. So normals 12 to 27. This is a study now years ago. I mean, look at this, 2006, when I was still giving talks for Nabido. Over 400 men, And they showed that once the total testosterone level starts going below 20 and it gets to around 15, which is still within the reference range, loss of libido, loss of vigor. Below 12 causes obesity. Below 10 causes depression, sleeping disorders, loss of concentration. Below 8 is the cause. Contributes towards cause of type 2 diabetes. Look, double digit. Look at the p-value. So it's why even before the GLPs, GIPs were launched, we had successes in terms of weight because we were using, remember I always said there are 7 causes of weight gain. So when you start working on all the other causes, indirectly, of course, the diabetes is going to improve. But this is a study that shows you from baseline over a 5-year period on patients who are testosterone deficient, you put them on testosterone, the average waist circumference was 108, and over a period of time, it dropped to 96. And that is a whopping 3 knot sizes, which means on average 15 to 20 kilogram weight loss. This is a big study. And the HbA1c dropped by 1.1. Remember, you only need a drug to drop an HbA1c by 0.7 to register it as a diabetic drug. So there are other ways of improving cardiometabolic conditions. And so just remember that there's many pathways. So here, it wasn't only testosterone, it wasn't only the optimization of the drugs that were used, but we started getting rid of the insulin and the diglyceride, which was contributing also to the weight gain. And he is off insulin, no BP meds. He opted to swap statins for natural cholesterol balance, and now only on glucophage. 2025. HbA1c 5.7. This one I'm going to leave. Okay. This is the politician. 61, when I met him, 61 years of age, HbA1c of 12.1 on 114 units of long-acting insulin on a shitty dose of glucophage, 1 Galvus, God knows what that was going to do, Ruvamol, and Lipent. Remember, this is the one who I said I was treating both husband and wife, both politicians, one busier than the other. The one was seeing me regularly. We reversed her diabetes. That's why she kept telling him, you must go, you must go, you must go. Anyway, came for one visit, disappeared. 3 years later, retired from politics, came back. And so he was diabetic for a long time already. You don't get to 112 units overnight. He's not much older. That's why I said I've been treating him for over a decade. And look, HbA1c by 2019 already 6. So much so that once you got to 5.7 in 2020, we stopped looking at HbA1c and now we just look at fasting glucose and insulin. And if you look at latest results, Homer index perfect, currently, yes, he's on testosterone, yes, he's on DHA, yes, he's on homocysteine balance, but he's on vitamin D and chose to remain on glucophage. So those of you who've been keeping attention and you look at the definition and you say, but one of the criteria for remission is that they mustn't be on drug. You guys already know, I've announced it a long time ago. I've been on glucophage for 22 years now. I'm not even diabetic. I wasn't even insulin resistant at the time. Last year, I became insulin resistant when I needed to go for back surgery because I became inactive from that spinal disc rupture. That's when I started noticing a bit of change. So I've also got that shit gene. But the point is, glucophage does not drop sugar. I showed you that. That was the first drug I discussed. So because a lot of these patients come to me just to manage their endocrinopathies and then they become part of this longevity and improved lifespan stuff, they realize that the benefit of glucophage is beyond glucose and insulin, and that it actually does have anti-aging properties proven to decrease risk of Alzheimer's, Parkinson's, heart attack, there's some stroke data and anti-cancer data as well. So from that perspective, it should be in the water. And so that's why some of these clients will choose to remain on this. So for me, what definition you use for remission doesn't matter. For me, remission means whatever it takes to get that client's HbA1c level, fasting glucose and insulin to that of a non-diabetic patient using the minimum amount of drug that doesn't cause cardiovascular risk. Because ultimately, that's what you do in longevity practice. The numbers need to look good. And so, do I have patients that have come off it completely? Yeah. I just gave you the example of the guy on the plate, and there's many more. But most of them do end up staying on some glucophage, mainly because of all the other benefits as well. So, when you got a patient in front of you, keep that mind map, know where each drug works, look at the metabolic status, look at the presence of fatty liver, because without managing that, you're not going to win. Get them on liver balance, NAC, heavy metal neutralizer. If the estrogen levels are high in the male and the testosterone levels are low, or they're both fine, but the ratios are off, give them an anti-estrogen, get the testosterone up. If the cortisols are high, fix the DHA cortisol ratios so that the body is moving towards laying down muscle as opposed to fat. All of those parameters are important. Work on the gut microbiome. So that's how we've been getting this right way before the GLPs came. Way before the GLPs came, right? Now it's easy with the GLPs. And so, no, there's a summary of what these things do. And so that way it's easy for you to choose the drug you need to. Now, why are the GLPs and the GIPs game changers? You don't have to take my word for it. Those of you who follow the market, you know that fucking ether just fell quite a bit over the last 2 days. And Bitcoin's correcting. The markets keep moving up and down. There's a lot of manipulation. But you will never find a 100-year-old company going up 700%. You will never find a 112-year company going up 500%. When old companies do well, they have a pedestrian 5% increase, 8% increase. It's the Teslas of the world that are new companies that will, 2x and 5x and that. And these companies that have produced these GLPs, they have gone up 500 and 700%. That is enough. Because the money on the market, they don't want to hear shit. They just want to see results. And money always follows results. I'm giving you the science. But these drugs are game changers. Every drug comes with its own ills. You need to know how to use and manage them, right? So, how do the GLPs work? And it's become very easy for you guys now to reverse type 2 diabetes. Problem is, if you leave these newer drugs to be used late in the course of the condition, then there's no beta cell to work on. Then the alpha cell's dead. So you're going to use it while all the organs are still good. So where does the GLP work? It works on the alpha cell by working on glucagon secretion. If you work on glucagon, you have better control over the hepatic stores of glucose. You have better glycogen metabolism. It works on the beta cells, stimulates insulin secretion, but in a time-sensitive manner. So as glucose levels drop, it stops secreting insulin. That's why it can't cause hypoglycemia. It works on insulin sensitivity. It decreases fatty liver. It improves lipotoxicity. It works on the brain by decreasing body weight, working on appetite and satiety, by working on the rewards dopamine center. It works by slowly emptying the gastric chamber. improve the glycemic index, work on the kidney, drops inflammation, improves insulin sensitivity, talks to fat cells. Because this drug on its own addresses so many, look, 1, 2, 3, 4, 5, 6, 8 out of those 11 factors, of course it's going to have a powerful effect in managing it. So the news flash is we will start the year off in 2026 with information on Hologain's new exciting products. It's going to be case studies. So in the beginning of the year, I think it's going to be good to start with case studies, a few thyroid, a few fatty liver, a few obesity cases, a few autoimmune cases, just to show you what longevity practice can achieve. And then we've already received quite a few ideas. Don't send us more because we've already got all our topics till November. Should you wish to become a stockist or need further information, please contact Leonie. And then some questions now. A few questions with diabetic. This is from, so Dr. Ghani sends me very interesting cases on a regular basis. I think she needs a desk next to me in the practice. Is there a normal or upper limit for a random insulin test? Never do a random insulin. That's what gave insulin a bad name. That's why a famous endocrinologist got it banned in South Africa, and that the medical aids used as a weapon and said, right, we don't want to pay for it. And it was all in bad jest because at the time he himself was doing clinical trials, and in clinical trials we use the HOMA index all the time to give us a surrogate marker of insulin resistance, because we can't do a clam test. But it is tests like this that forced him to stop doctors from using it, right? So if you do a fasting glucose and a fasting insulin, then you can measure what the insulin response is exactly to glucose and use HOMA index as a surrogate marker to measure insulin resistance. And that test is going to become standard. I showed you guys DeFranco's suggestion. So a few guidelines from now, 3-5 years from now, that's going to be standard. So a random doesn't mean anything, right? Because if I have a cake for supper, my insulin response is going to be much higher than if I just have a Coke or a biscuit. All of them will make it go up. So how do you measure today's random insulin against yesterday's when it's not standardized? Whereas if you fasted for at least 8 hours from 10 o'clock the night before and you did your levels between 6 and 9 and you are fasting, that means you've accounted for that fast. You've accounted for any other possible fluctuation. And whilst it not be 100% test, it's better than nothing. And the same people that said, oh, but insulin will keep changing. Well, so does glucose, and you haven't stopped your patients from measuring sugar levels. And so does blood pressure change, and you haven't stopped measuring blood pressure in your practice. And so does cholesterol, and you haven't stopped measuring cholesterol. So, yeah, it's the HOMA index is the way to go. Is there a good alternative to oral glucose tolerance test? I personally don't like it, and I'll openly say it. And the reason for that is I got good science. Years ago, we were taking part in a study by Novartis called the Navigator study. And it was to see if short-acting neteglanite, which is a short-acting SU, can it prevent the progression of pre-diabetes to type 2 diabetes. So guess what? You're looking for patients who are pre-diabetic. So we screened patients at Barra. And so how would you enroll a patient in that clinical trial? They said, once you've identified a patient who you think is pre-diabetic, how do you think this patient is pre-diabetic? Those days you never used H1C. So you had to do a glucose tolerance test. And a glucose tolerance test for pre-diabetes is your 2-hour level is above 7.8, but not above 11. And they said each person had to have 3 oral glucose tolerance tests, and 2 out of 3 had to show that the person got pre-diabetes before they get enrolled in this clinical trial. And they were looking for 5,000 patients worldwide. It was a huge study. And so I screened 30 patients. Each patient had to have oral glucose tolerance tests a week apart for 3 weeks. And I can tell you, not one GTT was repeatable. Not one. So each patient had to have 3, and the results were completely different. That's when I realized it was a useless test. The very thing they were excusing this thing for, but it was good for the time when we never had other tools. Do you see? So I don't use it. If there's no hemoglobinopathies, I use HbA1c. It's not cumbersome. It's a once-off test. It's giving you a 3-month average. You don't have to keep repeating it. And so a level above 6.5 gives me diabetes. But even a fasting glucose level above 7 is fine in the right context, right? Please advise on use of Ozempic and Mounjaro for overweight. Shit, what happened there? Sorry. This thing is trying to in my computer. Do you know? Okay. For overweight diabetic patients, how do we use and which one do we use? So remember, both Ozempic, which is semaglutide, and Mounjaro, which is tirzepatide, have been registered for type 2 diabetes, and they've also been registered for obesity. The Ozempic version that has been registered for obesity is called Wegovy. Ozempic is 0.25, 0.5, 1 milligram. And once it goes to 1.7 and 2.4, it's called Wegovy. Same product, just registrations are different. And Mounjaro is going to maintain the same name in South Africa, but it's registered for type 2 diabetes and for obesity. Overseas, the obesity version is called Z-bound. This guy comes in 2.5, 5, 7.5, 10, 12.5, 15, except for the 7.5. All of them are now in pens. The 7.5s come in November. So both of them can be used in overweight or obese patients with type 2 diabetes, provided they have got no history of pancreatitis, provided they don't binge drink, and warn them that the initial symptoms of nausea, bloating, loose stools may be there. And if you persist on low dose, slowly build it up, most patients can tolerate, and only about 5% actually end up not using it. And so how do we choose which one? Ozempic and Wegovy have been shown to have better cardiometabolic data. So you get weight loss, good weight loss, but the metabolic effects on the cardiovascular system are more beneficial in terms of heart attack. And I presented that online as part of the launch, because the launch took place over a 3-week period where myself and the GM went through that stuff, right? So those are available online. You can go and have a look at those, but lots of cardiometabolic and renal benefits. Mounjaro is a GIP and a GLP, so it's a dual peptide, and in the future there's triple peptides and many more other peptides coming, and the dual peptide has slightly less GIT side effects in majority of the patients. However, like today I had a patient where they asked, can they come off this and go on that, because they had more side effects on this one. So it varies, but generally less GIT side effects, and you've got higher doses that you can dial up to from a weight loss perspective, and by and large, that's how I would choose it, right? Is it possible to lower glucose too much if natural meds are given alongside allopathic meds, and how can we get the balance right? So if we go back, not all your drugs are going to cause hypoglycemia, you see? So the risk of hypoglycemia, GLPs, no. SGLT2s, no. TPP4s, no. Metformin, no. Pioglitazone, no. Insulin, yes. So insulin on its own, yes. SUs on their own, yes. Insulin and GLP, yes. But the GLPs moderate some of that hypoglycemia. That's why there's only one as opposed to two ups here. Can you see? And insulin and SUs, well, the game's over. So when you're using these drugs, that's when you got to worry about hypoglycemia, whether you're using it together or with other natural products. So the only natural products that directly drop glucose would be berberine to some extent. Most of its effect is like metformin, but to some extent can drop glucose, and Gymneva sylvestra. The rest, chromium, cinnamon, D-chiroinositol, betamelon, the names are escaping me now. HCA, West African mango extract, those don't cause hypoglycemia. They're working through some of the other pathways, PPAR, gamma pathways, insulin-resistant pathways like glucophage, working on the liver. So they typically should not cause hypoglycemia, right? Now, if you are using an allopathic agent that can cause hypoglycemia, then you need to watch. And hypoglycemia is a good sign. That means you can start weaning off either allopathic or the natural supplementation and slowly find the lowest possible drug you need to manage that HOMA index. Then another Dr. DM asked, and this Leonie, you see I got it right. I can type. So I typed it out now because this question just came in when I was at home. And the question is, if a person has been on Mounjaro for diabetes mellitus, can they ever stop it? Yes. Yes, I just showed you that, right? So, but you can only start considering stopping something when you got at least 15 to 20% of the weight down. Hopefully, a lot of it is visceral. If the patient has fatty liver, wait for the fatty liver to reverse. Those AST and ALTs need to be below 20. Make sure that there aren't other causes of weight gain left. Don't leave a thyroid unmanaged. Don't leave a cortisol DHA unbalanced. Don't not fix estrogen dominance in a perimenopausal female. Don't not fix a testosterone estrogen in a client. Work on the gut microbiome, because that way, once you come off Mounjaro, the weight should remain down. How many of you have seen people go on Mounjaro for weight loss or for diabetic control, and as they come off, the control or the weight comes back? That's because there's still another underlying cause of obesity that you haven't managed. So can you ever stop it? Yes. Or is it lifelong? And it can be lifelong. And if you use it lifelong, you can. It's safe enough to be used lifelong. What are the alternatives to Mounjaro injections for diabetic control? So I told you there's the semaglutides, there's the liraglutides, and the generics have come out. There's 3 generics on the market this year. So price is now no longer of concern. The SGLT2s, there's many generics on the market. There's pioglitazone still on the market. So I've gone through the alternatives through my armamentarium. So all of them except SU and the DPP4 inhibitor. Okay, Hologain is, so Hologain will close, or the last day for orders is Friday, the 12th of December. We reopen on the 6th. I think Leonie's in the office till the 18th, but delivery is till 12th. Some of our suppliers will remain open. So yeah, and then you can obviously get stuff from other suppliers or partners. I said I put this slide already in the beginning for your SPD certificate and what to look out for. Now, why did I put this slide here? Because echinacea is now proven as a bug to improve metabolic profile. And GT lean, with the highest dose of echinacea in the world, is coming to our shores. They're just waiting for the labels to be approved by SAPCRA. Products here already, and then it just needs to be bottled. So we keep telling people every 6 weeks, it's not our fault. We need the labels and NEPI codes and all of that registered, so it takes a while. So this Leonie is going to be having soon, and I can tell you There is not a product on the planet that can match the dose. The clinical trial showed that you need 60 billion. And yet the same people that showed the trial only got 10 billion in their product. This one has got a Comencia at 30 billion, but in a capsule that is acid resistant. So there's full delivery into the intestines. So you know that the stomach can knock out anywhere between 30 and 93% of the probiotic you're eating before it even gets into the intestines. So once you prevent that, all 30 billion are going, right? And so that study that showed 60 billion, you need at least 7 to 10 billion in an acid-resistant capsule. Well, this one's got 30 plus 8 other bugs that have been shown to improve weight and fatty liver. So anyway, I put it here because that will help in your management of patients with type 2 diabetes. I've given a talk on magnesium. Don't forget the importance of magnesium. Magnesium controls 400 different pathways. It acts as a cofactor. Magnesium, vitally important in the beta cell. We spoke about this in the past as well. So potassium, magnesium, chromium, very important. What's your sources? Dark green leafy vegetables, nuts, seeds, or take a supplement with glycinate, hopefully slow release, and then glucose balance. For the first time, a product with all 7 natural products, ingredients proven to drop glucose levels coming as well. And warmest regards from the Whole Again team. Leonie is looking forward to engaging with you guys next year. There's your guys' details. Last time I messed up, there were questions that came onto my WhatsApp, and I see Leonie hasn't put anything on. Leonie, are there any other questions? Let me just see. No sound. Please log out and log back in. Okay, so whenever there's no sound, guys, Leonie will let me know on my phone if it's me. So if I'm still talking, just you guys got to log off and go back on. This is recorded. Chris Fox is going to record it. Where's the questions, please? Live blood, guys. Okay, this is a talk on diabetes remission, but please elaborate on live blood analysis, Dr. Bana. I was unsure if I should delve into this due to lack of data, or as I'm not aware of it. Okay, so those of you who don't know what live blood analysis is, don't worry. You can send your stools off now to a couple of places in South Africa. One is very good in Pretoria. They basically analyze your entire gut microbiome. The results take about 2 weeks to come. They look at every one of those 100,000 different species. I just had my test done, and they basically classify it in different species, and then they make recommendations in terms of what ought to be done. It's an expensive test. If you want something cheaper and you don't need to know the name of the bug, contact Kim. Kim comes in our practice on a Monday afternoon, Wednesday morning, drops your blood on the microscope, shows the client and tapes the stuff in case their doctors decide that this is not a legit test. We send them the recording, and then we tell them to ask your doctor, what are these things on the slide floating around, moving around, and having a life on their own. And a live blood analysis basically looks at the rigidity of that single cell that's separating what's in your gut and you, because that's the lining of the gut. And when that becomes permeable, it's allowing things to come through. So the modern term for it is dysbiosis. The old term was leaky gut by homeopaths, and I like that term better. And gastroenterologists used to call it irritable bowel syndrome. Now it's a thing. And so Kim can then give you a breakdown of what's happening from a yeast, bacteria, parasite perspective, how the client is digesting stuff, and then manage the patient's gut problems a bit better. Tasneem. Okay, so those of you who need to log off and go to your dear ones, please do so. I won't feel offended. But I'm going to keep answering some of these questions. You guys are still going to get your 2 CPD points for this 2-hour session. So age 39, 10 months, weighs 102 kilos, previously 113 before Ozempic. So Ozempic got about 11 kilos weight gain. currently on 0.5 milligrams, diagnosed with PCOS at age 22, having regular periods, secondary infertility, diagnosed with MS 2022 based on having optic neuritis twice, 2 different episodes, 3 lesions on the brain MRI, oligobands found in the lumbar spine. New dosage of Ozempic is 1 milligram, H1C 5.6, fasting insulin. Carry on. Carry on. Because you need to carry on with your GLP until that fasting insulin, the HOMA index gets to 1, fasting insulin below 5. That thyroid looks sluggish. That estrogen progesterone ratios just slightly off, but that estrogen's high. So I would say you want to bring that estrogen down. Will liver balance affect how Ozempic is processed? No, it will improve it. Remember, liver balance got NAC and acetylcysteine, the direct precursor of the most powerful antioxidant in the body. We use it when there's a Panado overdose at Barra. We infuse it. It's available. And so it's NAC. It's got 750 milligrams. The next competitor has 600. The next one, I think Solal 500 and ACC 200. And now they've come up with the ACC 600 with a lot of sugar in it. So it's got 750 milligrams. It's got Kudzo. It's got dandelion extract. It's got alpha lipoic acid. It's got vitamin E that is permissible in South Africa at that dose. It's got green tea extract and 1 more. So it actually improves phase 1, phase 2 liver detoxification pathways. It will also help that estrogen, other meds, estrogen balance. Yeah, hopefully the patient's on 2, inositol, iron, vitamin D, magnesium. Vitamin D is very important for MS. And in MS, the reference range is 30 to 100. MS aim for 70 to 80, not 22. FOXA, alpha-GAN, loxoptopy is liver appropriate to any interaction. Okay, so carry on with exactly what you're doing. I would say go up on that Ozempic from 1 milligram to 1.7. Do that for 4 weeks, then go to 2.4. Stick with that dose. If the patient's got gastric side effects or the patient wants something else, then you can go on to Manjaro. If the client's on 1 milligram, you can jump straight to the 5 and then go to 7.5. And this patient, I think, will do well on 10. And if that estrogen level don't come down a bit more, I want it between 200 and 350, then I would say add a contraceptive. The contraceptive to use here will not be yes plus Zoli, Evra, Clara. Those are going to cause weight gain and spotting. Here you're going to have to use either Marvelon, Marvelon at 30 milligrams, and that should switch that estrogen off. What else? Yeah, I would say that would be my advice. Michelle, when do you initiate metformin off-label in practice? Oh, I told you I'm on it for the last 22 years. I don't even have the problem. In practice, I do it when the HOMA index is high and they got no intolerances to it and they understand that it's off-label. And yeah, I do that when the HOMA index is high. Can the link for vitamin D deficiency talk please be posted? Yeah, I'm sure. I think it's actually online somewhere, but Leonie will be able to answer that. What is your most preferred dietary intervention in practice for glucose intolerance? Insulin resistance is doable and sustainable, works most of the time. High protein helps with satiety, but probably not necessary to go extreme like carnivore. Okay, let's do that first. So what's workable? Guys, if you just had to see what I ate now, I had a very healthy meal and then I cheated a bit, right? So from that perspective, and I've got reason to, you guys don't have to know why, but I've got reason to. So it's okay to have a cheat day. So what I tell patients is that, listen, you're going to have to do this shit till you're 86 and a half years of age. So do something that is doable, that is intentional. and make it interesting. And do it with somebody if you can, like that couple from Clarksdorp, Posh area, right? So from that perspective, I tell patients who are insulin resistant, protein is not your enemy unless you got a problem digesting it, which is not an insulin resistant problem. Fat in somebody who is insulin resistant is not an issue, provided it's healthy fats. So from a quantity perspective, in my patients with insulin resistance, my enemy is carb. So I tell them, go home. I don't even give them a printout because I want them to do the work. They got to go home and Google high GI, low GI carbs. Of course, intermediate's going to come up. And I tell them it's going to categorize it as fruit, vegetables, cereals, grains, breads, and they'll see the shit that's there. And I tell them, 1 day a week, eat your heart out. Eat everything on that day. You're not allowed to spread your bet. But the other 6 days, no restrictions on carb for me, no restrictions on fat, unless they got problems with those issues. Watch your carbs. If you have to eat a carb, let it be low GI. If you're going to have a carb, it must be paired with protein. That's my advice. It's doable till you're 86 and a half. And so that's my advice. Have you heard of the 10 hacks for glucose insulin control by Jessie? Yeah, glucose goddess. Yeah, what are your thoughts? So, I mean, she's a famous YouTuber. And so if you saw those 11 things that I spoke about, you can see the 11 different organs. These hacks are about integrating lifestyles. At the end, whatever works for your client. And I tell patients, you want to go into paleo? Go for it. You want to do keto? Go for it. You want to do Atkins? Go for it. When you get heart fall, you come back to what I'm trying to tell you, which is more doable. So all of those things, they work. Some are calorie-based. Most of them are carb, denying the patient carbs or keeping it at a minimum or below 20 grams or 40 grams or whatever. But by and large, they work because you're not stimulating the beta cell. Thirdly, your thoughts on very good. It basically breaks habits, teaches, it's visible. Your CGM shows your client that on chickpea, this is what happened, and on a pasta, this is what happened. And so I tell my patients this. I said, if you've got too much money in your life, get the stuff. Get it for 2 weeks. But be conscious about what you're going to be over the 2 weeks. So you've got 3 meals a day times 14 days. That's 42 meals. Make each meal different, because normally we think we eat different foods, but if you map your food out, most of us eat 80-90% of the time the same thing. We just change the day of eating that sandwich and that pasta. So if you have 42 different meal experiences, so if you're having chicken and you're having it with pita bread or chicken with brown rice, there's a variation, right? Photograph your meal and see what happens. And that way you've learned from the 2-week experience, so you don't have to be on this thing forever. But if you need it forever and you can afford it, go for it. It changes habit. So that's good. Please repeat second natural agent that can drop glucose. Geneva sylvestra. That's why I don't use it. Please list 7 causes of obesity. Underactive thyroid. Adrenal issues. Low DHA, high cortisol. Cortisol is an anabolic. That's why when you give somebody cortisone, their insulin goes up, the sugar goes up, their weight goes up. Okay, that's why patients with Cushing's put on weight. That's why patients with Addison's lose weight. So you don't have to wait for these extreme conditions. There's stuff along the way. So adrenal gland is number 2. Estrogen dominance. That's why women in the perimenopausal state put on weight. They'll tell you, doctor, here's my watch. Look, I'm reaching my targets every day. I gym. I haven't changed the way I'm eating. And now I'm 46 and I'm putting on weight. What happens when you're pregnant? You put on weight. Of course, estrogen dominance is going to make you put on weight. So thyroid, adrenal, estrogen dominance. In males, it's testosterone going down and estrogen going up, right? The ratio changes. Thyroid, adrenal, estrogen dominance, fatty liver, gut microbiome, insulin resistance, and mitochondria. And I did 2 webinars on the mitochondria, guys. In the past, neurologists used to do a biopsy and say, yes, you got a mitochondriopathy. Now, you got a functional test, and they couldn't do anything about it. Because what do you do now? You've got a diagnosis. So now, and it's not their fault, but now you can send your bloods off to the University of San Diego, order the test online or ask Leonie where to get it. It's called capital letter ME, Google it, capital letter ME, screen, like you're screening somebody for diabetes, ME screen, and it will tell you what's wrong with the mitochondria and break it down and then even give suggestions in how to treat it. There's 14 different interventions that can be done to help the mitochondria. How do you know which one to use? So, yeah, so those are the causes, right? Gut microbiome, right? Thank you. You are welcome. Contact me. HbA1c is not reliable in patients with hemoglobinopathy. Yeah, that's why you can't use it. But remember, hemoglobinopathy is not a common condition, right? So we're talking about, by and large, you've got 100 clients, what's going to work in 99 of them. So that will work. So please elaborate, would this apply to iron deficiency anemia and low HB? So it will apply to a low HB. So if your hemoglobin is low, then you're under measuring your HbA1c. I'll tell you, I mean, I've had patients coming to me with the HbA1c of 6.5 and the doctor says, oh, excellent control. And you look at the hemoglobin and the patient's got an HbA1c of 11. Okay, the HbA1c is supposed to be around 13 and a half minimum if you like female. That means you're going to add 2 more points to that 6.5. Now that HbA1c is not well controlled. So yeah, that's why I said in the absence of any hemoglobin problems, right? Then you're going to have to use that fasting glucose story or your glucose tolerance test. You missed a question from Nadia. First question. Did I? What was the first question? Can you just put it on again on the chat? Then I'll find it again. Otherwise, I'm going to have to go back to the presentation. I've switched off. Can GLPs work on patients with pancreatic insufficiency? Was on Saxenda, stopped it, weight regained, and now BMI high. What do you mean by pancreatic insufficiency? So let me preempt this. If you've got a history of pancreatitis, you're going to have balls of steel to use GLPs and GIPs because the risk is higher, right? So from that perspective, if you mean pancreatic insufficiency, but not from pancreatitis where they're not producing enough enzymes, and so there's been no pain, there's no calcification of the pancreas, the insulin is still being secreted, but they find that the stools are floating and they're smelling and they're pale in color. Yeah, you can use it. Yeah, but then just help the pancreatic insufficiency with digestive enzymes. So I think in that context, it will be fine. Please assess. This patient has, okay. There's a patient with a BMI over 30. She wants to lose weight like yesterday. She had tried Ozempic, but says it didn't work. What could be the reason or lack of efficacy? Is Manjaro a good option for her? Or what else would you suggest? And then what happened to this? Oh, yeah. And then in terms of BP, 160 over 100 down to 150 over 90 in 2 weeks. Phil Alberts. Okay. All right. So here, I just had a patient today who was by a colleague of mine given Ozempic for 3 months and then changed to Manjaro for the last 2 months at a higher dose and still lost 0.5 kilograms. And truth be told, she needs to lose about 35 kilos. So the point is, I said there are 7 causes. So that's why we've been successful historically in being called a weight loss clinic. I'm not a weight loss clinic. I'm an endocrinologist. I want the weight to go down because it helps prevent diabetes. It drops the blood pressure. It decreases heart attack and stroke. It helps fatty liver. It gets people pregnant. The happy side effect of what we are doing was always weight loss, right? And so from that perspective, it's because we intervened on knowing that there are 7 causes of weight gain. Now, granted, the mitochondria only came in now as a test. We've always known about its importance, but we had the 6 things to work on. And so whilst we never had GLP, we could still work on insulin resistance because we didn't wait for the metformin to die. We were using these products as early as they came. And some of my patients used to get these products overseas when they weren't even launched in South Africa. But I still worked on thyroid, I still worked on adrenal, I still worked on estrogen dominance. And so here, if Ozempic did not work, so what's the definition of GLP or GIP working? You don't count the first month, low dose 0.25 once a week for 4 weeks. Then you go to 0.5. If you're on Saxenda, 0.6, 1.2, 1.8, 2.4, 3. Once you're on the maximum dose that you needed to be on 0.5 or the 1.8 on the liraglutide or the 3 milligrams on Saxenda, you need to be on it for 12 weeks. Once you've been on it for 12 weeks and you haven't lost at least 5% of your weight, the guys who make the product will tell you stop it. Because they're telling you there's something else there. So here, they need more tests. You need to find the other causes, right? And then this patient will desperately lose weight. Just you need to work on the other causes. So will Manjaro be a good option? Probably if you go higher dose, but is it going to work? Not to its full effect if Ozempic didn't bring anything down, right? So if you look at the weight data from Ozempic and Manjaro, they're similar, except for the higher dose of 12.5 and 15. And so from that perspective, yeah, I think you need to look for other causes. Is her lipoprotein level fine? Okay, lipoprotein's got nothing to do with weight loss. Lipoprotein's got to do with what's being carried from a cholesterol perspective. So lipoprotein little a is a shitty molecule. It carries LDL back to the scene of the crime. That's basically how I explain it to my clients, right? And we've been measuring it from the year 2000. I think I showed you guys an old slide. Now it's become fashionable because I remember one of my profs, I had to give a talk at the physician's update and rolling their eyes when I put this thing up. And at the time we were measuring lipoprotein big A, which is a good one, and big B, B1, that carries also the bad cholesterol, and the ratios are important. So that's important from a cholesterol perspective, from a heart attack and stroke perspective, but not with weight. So those are not weight related, right? And then, yeah, okay, sure, we're done. And it's exactly 9 o'clock, guys. So you've earned your 2 CPD points. I want to thank the 55 people that are still online. Shit, you guys got a lot more of attention span than I do. So thank you very much. Please enjoy the coming break. You know, if you don't take a break, if you don't do your breath work, if you got to look the part. I always say, look at your doctor. If they're looking the part, then you're at the right place. So you look the part, you be the change, and everybody else will get better. Enjoy the break. We'll see you guys in the new year. And if you need any other help, please speak to Leonie. And thanks for attending.